the approach we took to categorizing biomarkers is we divided the kind of available suite, if you will, of biomarkers. We didn't discuss every possible biomarker, but the ones we focused on were the ones that one are either available, commercially available to clinicians and researchers, or ones that are not yet commercially available, but look very good in research studies. And we think they're very likely to be beneficial for clinical practice at some point in the future. Again, not purely research, not purely clinical, but a blend. So the first thing we did, as I mentioned earlier, alluded to earlier, is we split categorization of biomarkers into biofluids, which could be CSF or plasma, versus imaging. We don't necessarily regard them as equivalent in all use cases. So fluid versus imaging, that's one distinction. Two, we divided biomarkers into three broad categories. So the first category is core biomarkers. So these would be biomarkers of the amyloid or tau pathology so core biomarkers then are specific for Alzheimer's disease. The second broad category is biomarkers that are not specific for Alzheimer's disease. They become abnormal in other conditions, but they're important in the pathogenic pathway of Alzheimer's disease. So these would be things like biomarkers of neurodegeneration, certainly important in Alzheimer's disease, but not specific for Alzheimer's disease. Biomarkers of inflammation. And we have labels for these. So neurodegeneration is N, the N category. I would be inflammation, or immune biomarkers of immune activation, immunologic activation. And then the third category is biomarkers of non-Alzheimer's co-pathology. So again, we have abbreviations. So V for vascular brain injury, S for biomarkers of alpha-synuclein, biomarker for alpha-synuclein. And the reason you might ask, why are you talking about biomarkers of non-Alzheimer's pathologies in a document that's focused on diagnosis and staging of Alzheimer's disease? And the answer is that we wanted this document to reflect reality. And reality is Alzheimer's disease in older people rarely exists in isolation. It almost always exists as a co-pathology with other pathologies like late disease, like cerebrovascular disease, et cetera. And so in order to accurately reflect current scientific thinking, current scientific evidence, we wanted to couch Alzheimer's disease in this background of associated or related pathologies. So those are the criteria we use to divide biomarkers or categorize biomarkers. Now, if we come into the core biomarkers, so these are biomarkers of A and T, we divide these into core 1 and core 2. So core 1 biomarkers are the A or biomarkers of the amyloid A beta pathway. These would be amyloid PET or A beta 42 to 40 biofluid measures. And then the core 2 biomarkers would be biomarkers of tau proteinopathy deposition. So this would be tau PET or biofluids that reflect that. And then finally, we split the core 1 biomarkers into A and T1 because it turns out that the biomarkers of hyperphosphorylated and secreted tau, p-tau 217, p-tau 181, et cetera, these become abnormal around the same time as amyloid PET. So we divide the core biomarkers into core 1 and core 2, with core 1 biomarkers being those biomarkers that become abnormal early in the disease process. And that's the category we use as the primary diagnostic category. And then core 2 would be biomarkers of that become abnormal later in the disease process. So those would be core 2 biomarkers. So I mentioned once we thought through categorization of biomarkers, how to categorize biomarkers in the current scientific environment. Next thing we tackled, if you will, is is use cases. And the most obvious use case that intended use or use case that people think about, of course, is diagnosis. And so our what we landed on in terms of use of biomarkers for diagnosis is that core 1 biomarkers alone are diagnostic of the disease process. And this is obviously where the controversy lies, and I'll get to this in a second. But we did not, so what are the core 1 biomarkers? The core 1 biomarkers are amyloid PET, number 1. Number 2, they are approved CSF assays. So CSF assays, A-beta 181 to 181 to, p-tau 181 to A-beta 42, total tau to 42, 42 to 40. So these are assays that have been approved by the FDA and also by European regulators. And then the third category would be plasma biomarkers that have excellent diagnostic performance. And we go into a lot of detail about what excellent diagnostic performance means. But a simple shorthand way to think about this is if a plasma biomarker has equivalent diagnostic accuracy for an accepted reference standard, like a positive amyloid PET scan or like a positive pathology, Alzheimer's pathology at autopsy, in the intended use population, equivalent to CSF, approved CSF assays, then the plasma biomarker meets the standard for a plasma biomarker that is fit for purpose of diagnosis. Now, there are a number of plasma assays out there that people are aware of. Not all of them meet the standard. In fact, a lot of them don't meet the standard, and if they do not meet that standard, they should not be considered fit for purpose of diagnosis. Other intended uses, of course, are biomarkers for staging, and here we have both the core 1 and the core 2 biomarkers, use of biomarkers to indicate as an indicator of treatment effects or target engagement, which we really don't spend any time at all talking about because we just to rein in the scope of the document, etc.